بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد صلى الله عليه وسلم وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the second part of the topic concerning anorectal imaging, and we have discussed in the first part the important subject of rectal cancer. Now we are going to discuss the rest of the lesions that can occur in the rectum, and in the following part, which is the third part, we will deal with imaging of the anal canal, inshallah. Here we would like to discuss the congenital and developmental lesions which occur in the retrorectal area or the presacral space, and these include the duplication cyst of the rectum, the tail gut duplication cyst, retrorectal dermoid, epidermoid, teratoma, anterior sacral meningocele, and neuroenteric cyst. Then we would like to have some information about the inflammatory conditions occurring in this area, including the perirectal abscess, idiopathic colitis, ulcerative colitis and Crohn's disease, colitis cystica profunda, and radiation proctitis. Then we will discuss some of the benign and the malignant lesions, including intradural hematoma, villus adenoma, rectal hemangioma, rectal endometriosis, rectal GIST, lymphoma, carcinoid, melanoma, and metastatic deposits to the rectum. In the third part, inshallah, we are going to discuss the anal anatomy and pathology. The presacral or the retrorectal lesions are many, and they include the previously mentioned cysts together with some of the tumors that can occur in this area, like neurogenic tumors and osseous tumors arising from the sacrum, like giant cell tumor, Ewing sarcoma, chordoma, and chordrosarcoma, and some of the miscellaneous lesions like anywhere in the body, including liposarcoma, fibrosarcoma, and others. And developmental cysts occur in the middle-aged, and then in particular they have some predilection to females, and they are asymptomatic in about half of the cases, and symptoms usually arise from the complications, and complications are almost similar for all the types of the cysts in this particular location, including infection, bleeding, and malignant transformation. The enteric cysts may compress the rectum or attach it to the rectal wall. Rectal duplication cysts is rare. Most of the lesions here are considered rare. Then the imaging findings are variable from simple cyst criteria, including paper thin wall, clear water content, well-defined sharp margin, and no internal septation, no calcification, no mural nodules, no enhancement, to a very complicated appearance, as I will show to you. And this is an example. You can see a cystic lesion, well-defined, clear water content in the presacral area, compressing and displacing the rectum. This cyst is not diagnostic for a particular lesion, but is included in the differential diagnosis. And most of these cysts, although they are benign, they have the tendency for malignant degeneration. So all these cysts should be surgically removed. Then the developmental cysts, as I have mentioned, include epidermoid, dermoid, enteric, tail gut, and rectal duplication cysts. They are relatively more common in females compared to the males. And the complications, as I have mentioned, also are almost similar for all lesions, including infection, bleeding, sometimes fistula, and malignant degeneration. Then I also have mentioned that about 50% of these lesions are asymptomatic, and the symptoms are related to complications, and the complications are almost similar for all the lesions. Then chronic infection may occur in these cysts. Then the resultant is a perirectal abscess, and this abscess may rupture and form perianal or anorectal fistulae. Then rectal bleeding in the duplication cyst may be related to the presence of ectopic gastric mucosa in the cyst itself. And malignant degeneration in these cysts is estimated to occur in about 7% of the enteric cysts. X-ray is not that helpful for evaluation of the developmental cysts. It may show some of the abnormalities in the sacrum and the coccyx. Then also some calcium may be present in some of these cysts, and also bone defects may be seen in the anterior sacral meningocele, for example. And if you inject barium, communication between the cyst and the anorectal lumen may be seen, and this is not common. The CT and the MRI are helpful in the evaluation, and they show a cyst with a variable criteria. And once more, these are the differential diagnosis of these cysts. Starting by the rectal duplication cyst, which is exactly similar to the esophageal duplication cyst occurring in the posterior mediastinum. But here there is a relative frequent incidence of this cyst to be infected and also to go into malignant degeneration. The cyst is located posterior to the rectum and in the presacral space, showing the typical cyst criteria unless it is complicated. And you got a clear water content, paper thin wall, no septation, and so on. And this is another appearance. You see a cystic lesion which is located in the presacral area, compressing the sacrum. Then the least common GI congenital cyst is that one which represents about 4% of the congenital cysts of the gastrointestinal tract. Then these lesions are almost asymptomatic, and symptoms are related to complications, and these are some of the symptoms of constipation, pressure effect on the rectum, tenesmus, and urine retention. And this is an example of a retention cyst, duplication cyst adjacent to the rectum by T2 and T1 both contrast with fat suppression. You got a clear fluid signal intensity with a minimal marginal enhancement, which is accepted in most of all cysts occurring in this particular area. Then on ultrasound, you may got some internal echoes within the cyst due to the presence of debris. And on CT, you will see the typical cyst criteria with no enhancement in most of the cases apart from minimal mural enhancement. On MRI, you will see the cyst of low signal in the T1 and high signal in the T2, and these cysts do not show any vascularity. Then you came to the tail gut duplication cyst, which is a famous one in this particular area, and it has a strong predilection for females. And sometimes this tail gut cyst is known as cystic hamartoma, pre-sacral or retrorectal hamartoma. And this duplication cyst occurs exclusively in the retrorectal or pre-sacral space, and it can appear at any age, but from 30 to 60 years is the usual age presentation. About 50% of the patients may have symptoms due to compression and pain, and sometimes constipation. The CT findings include a pre-sacral or retrorectal lesion that is well marginated. It contains internal septations, and hence you got multiple loculi, and these loculi contain different types of fluids like water, simple fluid, or mucinous fluid, and sometimes you got soft tissue density, and also calcification may be seen in the cyst wall. This lesion, similar to any lesion in this particular area, has tendency to for malignant degeneration, and if so, you will got a loss of the clear margins of the lesion and also involvement of the adjacent structures. This is considered the most, let us say, famous lesion of the group to be multilocular. Although other cysts may be multilocular, but you got a lesion with multiple internal septations, and sometimes you got a soft tissue component. It has the presacral or retrorectal location, and this is the CT appearance. MRI is very important actually because of many factors. Number one, it clearly demonstrates the internal septations. Number two, it clearly demonstrates the different signal intensities of the contents of the cysts. And here you may notice that there is some component of the lesion which shows high signal in the T1 and high signal in the T2 due to mucinous material. And this component of the lesion contains fluid which is of low signal in the T1 and high signal in the T2. After injection of contrast, you may got enhancement of the cyst wall and the septation, and if there is a soft tissue component, it may enhance as well. One of the important findings here is that the cyst will show diffusion restriction, especially the part which is containing mucin. Then this is one of the lesions that has a specific imaging criteria, an MRI being multilocular, different contents of the loculi, enhancement of the septa, solid component, and diffusion restriction. Then, as I have mentioned before, that surgery is indicated for all the cysts occurring in this area because of the complications. And this is an important statement in the literature that some of the reports suggest that a multilocular appearance with internal septation on T2 weighted image of a cyst in the retrorectal region is unique or are unique features to the tail gut cyst. Another appearance of a tail gut cyst in the this is T1 and this is T1 and this is T2 and this is T1 post contrast. And you can appreciate the high signal of the lesion in the T1 due to mucinous content, and here there is no significant enhancement. Then where is the loculi? And you can see this in different axial images, or you look to the sagittal image or the coronal reformatted images. And here you can see the appreciable diffusion restriction. This is the diffusion weighted image, and this is the EDC map. Another example of a tail gut cyst in the presacral area, low signal in the T1, low signal in the T2, marginal enhancement, and this is some of the locular appearance of the lesion, and this is the diffusion. Then you got marked high signal in the diffusion weighted image with drop of signal in the ETC map, diagnostic of diffusion restriction. Another example of a multilocular cyst in the presacral area with internal septation, low signal in the T1, intermediate, and this is T1 with fat suppression, and this is T2. The cyst showed high signal intensity. Then, as I have mentioned before, these cysts are liable for malignant degeneration, and this is an example. And you see a cystic lesion in the presacral area. After injection of contrast, you can see an enhancing solid component. Then I have mentioned that the tail gut cyst without malignant degeneration may contain a soft tissue component. Then how can you discriminate between a benign tail gut cyst containing a soft tissue component and the malignant one with a soft tissue component? I have mentioned before that the malignant degeneration will result in abnormal infiltrative margin of the lesion that can be invading the adjacent structures. And one of the informations that is worth to know is biopsy is not recommended in these cystic lesions, as all the cysts will be removed surgically. Then this cyst, if it is benign, it will be removed. If it is malignant, it will be removed also. The presacral epidermoid cyst is also common in females compared to males, and most of the lesions are asymptomatic. They may cause pain not, not, as a sequelae of complications, and you know that epidermoid cyst is one of the lesions that produce diffusion restriction on diffusion weighted MR images. And this is also noticed in the tail gut cyst. But the literature says that the epidermoid cyst is the only one that can produce diffusion restriction, but you have seen already many examples of a tail gut cyst because of the mucin content showing diffusion restriction. The epidermoid cyst may show hypointensity in the T1 and hyperintensity on the T2, and also it may show T2 hypointense due to the presence of creatine inside the lesion. The main complications are the risk of malignancy and the infection. Then signs of development of malignancy in the cyst include heterogeneous signal, irregular wall, solid component, the presence of enhancement, and other signs of malignancy, including invasion of the adjacent structures. And this is a cystic lesion which is located in the presacral area, compressing and displacing the rectum. It contains almost clear fluid content. The MRI showed In the T1 fat suppressed image, the cyst is hyper intense due to the presence of keratin material, and this is the T2 weighted image, and after contrast the cysts do not show significant contrast enhancement. Another presacral epidermoid cyst, the cystic lesion and the presacral area, then in the T2 weighted image it does not show significant hyperintensity. At the end of this lecture, I will provide a scheme for the differential diagnosis of most of the lesions mentioned in the lecture. And this is another appearance of a multilocular cyst in the pre-sacral area that has been proved to be an epidermoid cyst. In the T1 weighted image, the cyst shows some intermediate signal. After contrast injection, the cysts do not show significant enhancement. Then here another example of an epidermoid cyst in the presacral area, the big lesion with low signal in the T1 and the heterogeneous signal in the T2, and also you can appreciate the sacral deformity, denoting that this is a long-standing lesion in this particular area. Then you know from the previous lectures that dermoid cyst is diagnosed by the presence of fat and calcium. This is also true for the dermoid cysts occurring in the presacral area, but in many cases you do not see fat, let us say gross fat in the lesion, and you may got some minimal calcification. And this is an example of presacral dermoid cyst. The dermoid cyst here is of a bright signal in the T2 and dark signal in the T1 with no appreciable post-contrast enhancement. There is no gross fat within the lesion, and also MRI is insensitive for the detection of calcium. Then what to do for a lesion like this? And if you look to this lesion and you see a cystic lesion with almost simple cyst criteria with no internal septations and no solid component, then this cyst can be included in the differential diagnosis of presacral or retrorectal duplication cyst. And duplication cyst will give similar appearance, but tail gut cyst is not included here because tail gut has some specific criteria. Also, you may include in the differential diagnosis the epidermoid cyst. And this is a cystic lesion which is multilocular. And in the T1 weighted image, you may appreciate some of the high signal foci denoting the presence of fat. And also you got fluid within the lesion. If you inject contrast material, it will not enhance. And also you see the anomalous changes in the sacrum and the form of fusion of the sacral segments and underdevelopment of the coccygeal segments. Then there is a syndrome which is known as Corino syndrome, which is a malformation associating sacral agenesis, anorectal malformation, and a presacral tumor. And you may diagnose this Corino syndrome, and you may say that this is a lesion in the presacral space. And the differential diagnosis of multilocular lesion is the tail gut cyst, which is the most famous one in this particular area. But the presence of fat, even if it is nil, you will direct your attention to the possibility of dermoid cyst. And here you see minimal enhancement of the cyst wall. And this is a clear-cut example of a dermoid cyst present in the presacral area, where you got fat globules. You remember the sack of marble, which is one of the criteria of a dermoid cyst in the mouth floor. You got high signal intensity in the T1 and the low signal intensity in the T2, floating within the cyst fluid, which is of low signal in the T1 and high signal in the T2. Then, if you see some brightness in the T1 weighted image, you may consider the presence of fat, and also you may consider the presence of blood. Then this is a cystic lesion which contains a high signal contents in the T1 that became of low signal intensity, and the T2 supporting the possibility of fat in the retrorectal space, diagnostic of presacral dermoid cyst. And according to the literature, it is difficult to differentiate between teratoma and the dermoid cyst in the presacral area, because both of the lesions are diagnosed based on the presence of calcium and fat. Then the difference between teratoma and the dermoid cyst lies in the tissue of origin. And you know that this lesion is arising from all the three layers of the tissues, while the dermoid cyst arises only from the ectoderm. And teratoma may be divided or classified into three types: the mature one, the immature, and the malignant one. The incidence of malignancy is about 8% if the lesion is diagnosed before the age of 2 months. And this incidence is markedly elevated up to 60% if the lesion is diagnosed after this age. Then you may got some calcium in the lesion, and the calcium is more common in the benign forms compared to the malignant forms. And these are the signs of malignancy: large tumor with central necrosis, poor definition of the margins, sacral invasion, locoregional lymph nodes, and distant metastasis. Most of the presacral teratomas contain solid and cystic areas. Also, you may got a completely solid teratoma, which will be difficult to be included in the cystic lesions, in the differential diagnosis of the cystic lesions, but will be included in the differential diagnosis of the solid lesions, to be mentioned later on in this topic. The symptoms of all of these lesions are non-specific. They may include pain and the pressure symptoms due to compression of the rectum or the bladder if they are big. Surgical excision is the treatment of a choice for all the presacral developmental cysts. And this arrow points to a rim of calcium within a presacral cystic lesion, and in the T2 weighted image you got some drop of signal, and this was proved to be a presacral teratoma. Another example of a presacral teratoma in a female patient presented by low backache for 2 weeks, and he had a history of operated presacral mass in the neonatal period. And here you got in the pre-contrast image a cystic lesion in the retrorectal space, displacing the rectum anteriorly. After injection of contrast, you got minimal enhancement. And this is the appearance of the lesion in the T1 weighted image. You got some brightness with fine internal septations. In the T2 weighted image, you see a cystic component, and this which looks like solid component made of fat, and this is the diffusion weighted images, and you got some diffusion restriction in the lesion. And this is another uh, example of a presacral teratoma where the barium enema showed some extrinsic compression on the rectum, and the CT showed a thick margin cystic lesion in the presacral space. It appears a unilocular lesion, but this was proved to be a presacral teratoma. Another example in this image is obtained in the prone position, and you got fat and fluid and also some solid soft tissue components in this presacral teratoma. Then you came to the anterior sacral meningocele, which is a herniation of a meningeal sac, and instead of going back and posteriorly, it herniates through a defect in the sacral vertebrae anteriorly, posterior to the rectum, which is compressed. And this lesion is relatively easy to diagnose based on the classic appearance. The anterior sacral meningocele represents about 50% of the retrorectal masses. It has some predilection for females, similar to the rest of the cysts. The symptoms are non-specific, and they depend mainly on the compression symptoms resulting in constipation, urinary dysfunction, dysmenorrhea, and low back pain. The MRI is good for the demonstration of the communication between the cyst and the spinal canal. And sometimes this communication may be difficult to be detected, and at that time the conventional myelography may be of much help. Uh, Anterior sacral meningoceles do not regress spontaneously, and they need to be surgically treated because of the fear of infection, which will lead to meningitis. In the plain film, you got a classic deformity of the sacrum, which is known as scimitar sign, where you got this deformity of the sacrum. On the CT and the MRI, you got a lesion, and this lesion is connected to the spinal canal through a defect or through the absence of some of the sacral vertebrae. And this cystic lesion, you see air, and air means that it is infected, and in that time the CSF culture revealed the presence of the fecal flora. And this is the 3D CT image showing beautifully the scimitar appearance of the sacrum. An example of a big cystic lesion containing clear fluid density, and this lesion is communicating with the spinal canal through the defect in the second sacral vertebra. Another lesion which shows the classic fluid signal or CSF signal in all pulse sequences, the low signal in the T1, high signal in the T2. The cyst is communicating with the spinal canal, and the cyst will not enhance after injection of contrast. Some of the complications of these cysts are the bleeding, and this is a big anterior sacral meningocele, you see the defect in the vertebrae with some hyperdensities inside the cyst denoting the presence of hemorrhage. And this has been also shown by MRI. You got the bright signal foci. Of course, these are not fat because they see hemorrhage in the CT scan. And also you got these lesions of very dark signal in the T2 weighted image, which is the characteristic signal of bleeding. And this is the photograph during surgery for this cyst, and this is the MRI sagittal T2 weighted image after excision of the cyst. Then the last one in this group is the neuroenteric cyst, and this is easily diagnosed by the presence of a cystic lesion that has a component inside the spinal canal and another component in the presacral area associated with anomalies of the spinal column. Then this lesion is usually diagnosed in the pediatric age group, and the average age is about 7 years. Then some of the other congenital anomalies in the gastrointestinal tract, in the kidney, in the heart may be associated with this neuroenteric cyst. Then we came to the infection and inflammatory conditions. The majority of infections and inflammatory conditions in this area are idiopathic, and the symptoms are non-specific. Then, when you diagnose infection or inflammatory condition, at that time, CT or MRI may be helpful to assess. Number one, the extent and severity of the disease. Number two, identify the complications like abscesses and their extension. And the, the source of infection of the rectum is an anorectal inflammatory disease in most of the cases. Other causes are rectal perforation, surgery, and pelvic inflammatory disease and trauma. Then the anorectal inflammation may result in the formation of a perirectal abscess or presacral abscess, and the abscess has the criteria of an abscess everywhere in the body: marginal enhancement, internal fluid density of some hyperdensity due to the presence of pus, some air loculi, stranding of the surrounding fat planes. These are the criteria, including that the abscess will show diffusion restriction on diffusion weighted image. And this is an example of a pre-rectal abscess. You see, this is the injected contrast through the rectum, and here you got multilocular lesion with marginal enhancement and some stranding of the surrounding fat. The lesion is bulging into the left ischiocrectal fossa, and this is, as I have mentioned, the contrast material injected in the colon. Another example, then you see a perirectal abscess with air loculi and inflammatory granulation tissue surrounding the rectum with haziness of the adjacent fat planes. Then the two famous inflammatory lesions affecting the colon and the intestine are the ulcerative colitis and the Crohn's disease. You know the difference between both by the distribution, since ulcerative colitis will affect the distal part of the colon, while Crohn's disease will affect mainly the small bowel and some particular areas in the colon, including the proximal segment of the ascending colon, the distal segment of the transverse colon, and the sigmoid. But in all conditions, you got similar imaging finding of both lesions, including rectal wall thickening, contrast enhancement, mural stratification means you got layers in the affected segment with different densities and signal intensities. Hyperintensity of the rectal wall on T2 due to mucosal edema, sinus tract fistulae and abscesses, luminal narrowing, lymph node enlargement, perianal and perineal abscesses, which are an important feature of Crohn's disease, and this will be, inshallah, discussed thoroughly in the next lecture, inshallah. Then you got fibrofatty proliferation and the skip lesions, which is one of the known criteria of the Crohn's disease. Although we know that the rectum is affected by ulcerative colitis, but Crohn's disease is also one of the lesions that can contribute to this infection. This patient had a 3 weeks history of bloody diarrhea. You see that there are some prominent imprints on the wall of the gas-filled colon, and they are suggestive, of course, not diagnostic, of mucosal edema, which is confirmed by CT, and you see that the colonic wall is thick and is marginally enhanced, and he got some dilatation with this well-known sign, which is known as the target sign, where you got mucosal edema of the affected segment. Another appearance, there is no imaging feature to differentiate between Crohn's and ulcerative colitis in the intestine. You got I mean in the affection of the intestinal wall, but of course the presence of skip lesions, the presence of fistulae are much more supporting the possibility of Crohn's disease. But if you look to this appearance and you got thickening of the rectal wall and rectal sigmoid, you got mucosal edema, you got enhancement, you got stranding of the fat planes, and you got also fluid in the pelvis. And then if I ask you, what do you think of this lesion? Is it Crohn's or ulcerative colitis? You may say that because of the affection of the rectum, I prefer the diagnosis of ulcerative colitis, and this is true. But put in your mind that Crohn's disease will have exactly the similar appearance. Then this actually is known as a fat halo sign, and you got a layer of fat instead of fluid. If this is fluid, it's known as target sign. If this is fat, it is known as the fat halo sign, which may support at that time some of the let's say inflammatory condition. But if you do not see a stranding of the colic fat and there are no signs of infection, sometimes you consider this as a normal finding. And here is a case of ulcerative colitis with thickening of the wall, a stranding of the perirectal fat, and the enhancement of the wall. And in case of Crohn's disease, showing a stricture affection of a segment of the small bowel, and this is the transition zone. There is a proximal dilatation, and here you see affection of the rectosigmoid area, which is not considerably different from the affection of ulcerative colitis. And this is also an example of Crohn's disease. Then you got the similar manifestations to ulcerative colitis in the form of thickening of the wall, enhancement and stranding of the colic fat. Uh, uh, some of these strands will result from a famous sign which is known as the comb sign. and this is the comb sign where you got reticulations in the pericolic fat plane and engorgement of the vascularity, resulting in this classic appearance. And this is a case of Crohn's disease where you got thickening, marked thickening of the wall of the rectosigmoid area, and this is a fistulous tract between the affected segment and the skin or the peritoneum, then to the skin. Then we came to a lesion which is relatively, it is uncommon. It is a benign condition affecting the colon, which is known as colitis cystica profunda. From its name, there are multiple cystic lesions in the wall of the colon, and they are present in the submucosal space. The etiology of this disease is not exactly known, and the symptoms include bleeding, mucus discharge, pain, diarrhea, and tenesmus. And then for the diagnosis, you may go by endoscope and have a biopsy. There are three forms of this colitis cystica profunda. The diffuse form is associated with inflammatory bowel disease, and cystic lesions are observed all through the colon. They are pedunculated or villous polypoid lesions, and sometimes they contain ulcers. The segmental form is a polypoid lesion seen in one or more sections of the colon, not all the colon, and typically seen in the rectosigmoid. The localized form are in the form of polyps that are particularly located in the rectum, about 5 to 12 centimeter from the anal verge. Then the appearance on imaging is not that specific. You may see that there are submucosal cystic lesions within the rectum with loss of the perirectal fat planes, asymmetrical thickening of the levator ani, and in this disease there is no regional lymphadenopathy, and the lesions may show some contrast enhancement, and also they may show some focal calcifications like in this area. This is the schematic representation of the exact location of the cyst. It is located in the submucosal area, but actually in imaging you cannot decide this. Here you see that the rectum is the rectal wall is diffusely thickened, and you got a cystic lesion within the wall. But on MRI, you may be able to see that the lesions are located in the submucosal space, and these lesions do not show diffusion restriction. They are bright in the diffusion weighted image and also bright in the EDC, what's known as the T2 shine through. Another lesion by endoscopic ultrasound, and you got a well demarcated cystic lesion in the submucosa. Here you may see some calcium, and this is the cystic lesion. And this is also a good example of colitis cystica profunda. You got lesions in the submucosa, they may show calcium, and these lesions in this endoscopic ultrasound do not look totally cystic, and by the endoscope you can appreciate the submucosal location of the lesion. Then the pelvis is frequently irradiated, especially in the presence of rectal malignancies and gynecologic malignancies. This radiation will affect the colon in the form of inflammatory changes that are exactly similar to the previously mentioned signs. And you got edematous changes in the colonic wall or the affected segment, and you got some enhancement, and you got a stranding of the pericolic fat planes, and this is diagnosed as inflammatory changes, and in the presence of a clear history of previous irradiation, you may call that this is a radiation sequelae. And here you got some thickening of the mucosa of the rectosigmoid, edematous changes in the rectum, which are also seen in the CT scan in a patient that has been irradiated for vaginal cancer. And all what happens in the rectum can also occur in the small and large bowel in the form of mucosal thickening and edematous changes with stranding of the varicolic fat. Sometimes you got extension of these inflammatory changes into the perirectal space and result in the formation of an abscess like this one, where you got marginal enhancement and you got internal air loculi. This is the difference between the fat halo sign and the target sign. The fat halo sign is a layer of fat in the wall of the rectum, and this may indicate a the sequelae of chronic infection if there are other signs to support the infection. But this is an acute infection where you got mucosal edema, fluid in the wall of the rectum. Then this is also another example of inflammatory condition affecting the rectum and the sigmoid with diffuse edematous thickening of the wall and the stranding of the varicolic fat, which is clearly identified in the coronal reformatted images. Actually, this lesion cannot be easily differentiated from carcinoma in this area, and many times you need the help of endoscope to discriminate between both lesions. And this is the sagittal images of the same case. Here you can feel that you are dealing with an inflammatory condition. In the coronal images, you may got the impression of a malignant lesion. Then three benign lesions occur in the wall of the rectum, and or let us say four: intramural hematoma, and diffuse hemangioma, villus adenoma, and endometriosis. Intramural hematoma is uncommon and is mostly related to trauma. 25% of hematomas are spontaneous and may be related to the anticoagulant use or hematologic disorders. Hematomas will present by obstructive symptoms. Hematomas can show hyperdensity on CT scan, and on CT scan you also may detect contrast extravasation denoting active bleeding. Hematomas do not calcify and do not infiltrate the adjacent organs. And this is a patient on therapeutic anticoagulant for pulmonary embolism, was administered because of severe constipation. And you see, the colon is overloaded by fecal material. And treating this condition by cleansing enema and so has resulted in a big intramural hematoma in the rectum. And this is another example of a hematoma in the rectum. And here you can see the hyperdensities along the rectal wall, and these are due to the contrast extravasation. This patient was treated for hemorrhoids, and there is active bleeding in the wall of the rectum. Another patient who using anticoagulant prophylaxis, and he has been subjected to trauma through a fall, and presented by this big lesion in the rectum. And here you can appreciate the presence of a facial fracture in the sacrum. Then we came to the vellus polyp or vellus adenoma, which is most commonly found in the rectum, and it is considered the least common of all polyps occurring in the colon, and this polyp is almost particularly arising in the rectum. The polyp is hypersecretory, leading to diarrhea, fluid and protein and electrolyte disturbance. Some of other symptoms like bowel obstruction, bleeding resulting in anemia may occur. This polyp is a precursor to cancer. The polyp will appear on the CT image as a broad base, big polyp that has some folds. And if you inject barium, barium will go in between the clefts of the polyp. On MRI, you got this particular appearance, which is known as the carpet-like flat lobulated lesion I will show. Then on CT and CT colonography, you may appreciate the appearance of the lesion, but this polyp will result in luminal expansion and may lead to sometimes into intussusception. This is the gross appearance of the polyp, and the appearance by CT. You got a lobulated enhancing mass within the rectal lumen, but the appearance on MRI is relatively characteristic, where you got low signal appearance in the T1 and some increased signal in the T2 weighted image. And this is the what I mean by the polyp, and this is rectal gel. And here you got the classic appearance of the vellus adenoma or the vellus polyp. You see these projections and the fluid going in between the projections. If you inject contrast material, the polyp will enhance. And this is the appearance of the polyp in the sagittal image. You got the vellus projections, and these projections will enhance after contrast injection, exactly similar to the carpet. Special type of the carpet would got vellus appearances exactly similar to this. And this is another appearance of a polyp, which is the vellus type, expanding the rectum, having the classic appearance. And if you inject contrast material, you got significant contrast enhancement. Then diffuse cavernous hemangioma of the rectum is also one of the known lesions in this particular area, although it is rare, but it can have some of the classic diagnostic features. And these classic diagnostic features include large number of calcified pelvic philippuli, history of chronic rectal bleeding in young adult, moderate high T2 signal intensity, markedly thickened rectosigmoid wall, high signal heterogeneous perirectal fatty tissue with vessels enhancing serpiginous structure, representing small vessels supplying the malformation. These lesions are present in young adults, and the age presentation around 12 years. The main symptom is bleeding, and it's occur in about 75% of the cases. Other symptoms include anemia and intestinal obstruction. 10% of the patients may be asymptomatic. And one of the good diagnostic criteria is the presence of a large number of grouped philippuli in the pelvis. And the philippuli are present in the rectosigmoid area. Barium enema will show nodular filling defects I will show. Then you may got the dilated veins seen by colonoscopy. Endoscopy is of course not recommended because of the high risk of bleeding. Then the when to consider the possibility of hemangioma if you are faced by a young adult with lower GI bleeding, and this bleeding is painless and exists since childhood, and if you have just a plain film of the region of the pelvis and you got too many calcified philippuli, and this is a classic appearance. If you do not know this lesion, you will diagnose this as simple philippuli. But you remember that simple philippuli are few and they are usually seen in old age. But these are too much philippuli and seen in a very young age, then you consider this possibility. In the barium enema, you got multiple impressions representing the dilated vessels on the colonic wall. And on the CT scan, you'll see diffuse thickening of the wall of the colon, and you will detect the philippuli. And this is a very impressive image obtained during surgery where you can see the engorged dilated veins in the wall of the colon together with the calcified philippuli. And this is also another example. You got pelvic philippuli and you got diffuse thickening with nodular high signal intensities in the wall of the colon, and these nodules will enhance significantly after injection of contrast. And this is another example by the endoscope and by CT. You see the philippuli and you see the dilated engorged veins, and by MRI you see too many small vessels in around the rectum, which are clearly also appreciated in the diffusion weighted image. Then endometriosis means that there is an endometrial-like tissue in an ectopic place, and one of these ectopic sites is the colon or the intestine in general. And the condition affects the intestine in about 25% of the pelvic endometriosis, and this is not a rare condition among the women in a childbearing age. The symptoms include pain and blood with stools. They are not specific, and symptoms of of pain or the symptoms associated with the menstrual cycle or cyclic bleeding, cyclic pain are present in only 40% of the patients. MRI will show a lesion that is of relative hyperintensity on the T1 and hypointensity on the T2 that is located in the anterior aspect of the uh, erectosigmoid area. And also you may got inside the lesion. You remember the adenomyomatosis of the uterus, where you got ectopic endometrium in the myometrium. One of the diagnostic criteria is the presence of bright signal foci within the lesion, as I will show. Then sometimes you may use barium enema, you may use enteroclysis, you may use CT enterography in order to detect the lesion. And this is, in my opinion, one of the classic appearances of colonic endometriosis. You got mucosal thickening and irregularity of the inferior wall of the rectosigmoid junction. If you see this, and of course you are dealing with a female patient, then you may consider this and you may have ultrasound or CT or what other imaging modalities to support your diagnosis. Then here you see a big lesion between the uterus and the colon, and then these are the bright signal foci that I have mentioned, which are present in the T2 and also in the T1 weighted image. They are not present in every case, but they are diagnostic if you see this. They always in the literature, they say that endometriosis looks like the mushroom appearance, which may be so in some of the cases. This is uh, MRI after introducing gel in the colon and in the bladder. And you got a lesion in the colon and another lesion in the bladder. And you see the bright signal foci in the T2 and also in the T1 weighted image. This is a helpful diagnostic sign, but it's not present in all cases. Then we have the remaining few lesions that are malignant in this particular area, including the guest tumor, the lymphoma, and the carcinoid tumor. Anorectal guest tumor is rare. Then you remember, I have mentioned this elsewhere in the lectures of the GIT, that guest tumor can affect all the sides of the gastrointestinal tract from the esophagus down to the rectum, but the rectum is one of the rare sites. Then just are expanding lesions, and they are diagnosed usually in old age. They have a male predominance, and they present by rectal bleeding. On CT, the tumors are relatively hypodense to the muscles. On MRI, they show the signal intensity similar to any other tumor. There are no specific signal intensity to discriminate the guest tumor. But calcium can occur and also hemorrhage. You remember that guest tumor is liable for ulceration and the bleeding. It is a metabolically active lesion on PET-CT. And this is one of the criteria of the guest tumor, that is bulboid lesion or bulky lesion, where with the signal intensity similar to the any other tumor, which may be of intermediate signal in the T1 and relatively high signal in the T2. Big lesions may have central areas of necrosis. This lesion is not associated with lymphadenopathy. And this is a guest tumor, which is a bulky lesion with a big tendency to extend into the ischiorectal fossa. This is a newly introduced drug which is known as imatinib, and this proved to be a good therapeutic agent to be in cases of guest tumors before surgery. And you can see here, this is the tumor before imatinib, and this is after the therapy. You got significant reduction in the tumor size, which will allow a more conservative surgery, especially to preserve the rectal function. And this is another example. You see a big bulboid lesion in the rectum with tendency to go into the ischiorectal fossa, and after imatinib therapy, you got significant reduction in the size of the tumor. These are the differences between cancer and the guest. The cancer is usually circumferential with luminal narrowing and infiltrative margin with affection of the perirectal fat and frequently associated with metastatic lymph nodes. But the guest tumor is exophytic, non-circumferential, is a bulboid lesion, and it has a tendency to go to the ischiorectal fat and is not associated with lymph node metastasis. Lymphoma can affect the colorectal area and is usually seen in the 5th to the seventh decade, particularly in patients with lowered immunity, as in AIDS or organ transplantation, or those who are associated with inflammatory bowel disease. The symptoms are not specific. Weight loss and abdominal pain. Bleeding is seen in about 20% of the cases. Then 50% of the patients have palpable abdominal mass, because the lesion usually presents in a bulky appearance, and the obstruction to the colon is rare. Lymphoma do not ulcerate and do not cause obstruction. And here a rectal lymphoma, the big mass with central areas of necrosis, and it circumferentially surrounds the colonic lumen, or may result in multiple focal nodules. And lymphomas are usually large, bulboid lesions with unusual ulceration, and diagnosis is reached by endoscopy. And this is another example of a rectal lymphoma, marked circumferential mural thickening encroaching significantly on the lumen, which is not obstructed. And this is a CT scan and MRI of a huge lesion affecting the rectosigmoid area that has been proved to be colorectal lymphoma. And on the CT scan, frequently you see enlargement of the regional lymph nodes, and also enlargement of the abdominal para-aortic lymph nodes. The lymph nodes of lymphoma are bulky and they are homogeneous. They do not contain calcium or areas of breakdown in most of the cases. And this is a mass which is located in the left side of the colon, that cannot be discriminated actually from rectal carcinoma. But this lesion showed diffusion restriction. Rectal cancer also shows diffusion restriction, and it proved to be rectal lymphoma. And this is the EDC showing the decreased signal intensity. Then we came to the carcinoid tumor, which is a rare also lesion present in the rectum. GIT carcinoids represent about 70% of all carcinoids, and about 25% of the GI carcinoids occur in the rectum and the appendix, you remember. These lesions are solitary, they are smooth, rounded, and they are usually small. And the medium size of the tumor is in the range of 6 millimeter in diameter. The lesions are usually diagnosed incidentally in about 30% of the cases. And the treatment may be by bulbectomy through endoscope. Then the size of carcinoid tumor is an important prognostic factor, since the lesions below 1 centimeter are considered benign. Carcinoid is a hypervascular lesion that enhances considerably with injection of contrast material. And you see this lesion, bulboid lesion in the rectum, which cannot actually be differentiated from the rectal cancer. But on endoscope, you see the very smooth lesion, which is the submucosal lesion, and sometimes the carcinoids are detected by their metastatic lesions, especially to the liver, as you can see in this case. And this is also a carcinoid lesion, submucosal hypervascular lesion, and by endoscope, and this is by endoscopic ultrasound. 25% of GI carcinoids are located in the rectum. They are symptomatic, detected incidentally by the endoscope. Then here you see a big lesion by CT, and this is the lesion by MRI, and this is MRI post contrast. And here is the coronal T2 weighted images, and you can see the lesion in the rectum with diffusion restriction. And melanoma is an extremely rare lesion and is a highly aggressive tumor that may occur in the rectum. Sometimes the lesions are bulky and they protrude from the anal canal. And according to the literature, bulky fungating mass in the distal rectum without obstruction may suggest the possibility of melanoma. Sometimes the MRI is helpful to predict the melanotic part of the tumor by the detection of high signal lesion of melanin and the T1 weighted image. Then here you can see a bulboid lesion in the rectum associated with enlargement of the lymph nodes, which cannot actually be discriminated from rectal cancer. Another lesion by endoscopic ultrasound, and in the T1 you got high signal, and this high signal may be due to fat, due to blood, due to melanin, and in this particular case it was due to melanin in melanotic melanoma, and similar to any of the malignancies occurring here, they show diffusion restriction. Then finally, metastasis to the rectum. This is not a common lesion, but the more common is to get invasion of the rectum by the nearby malignancies, like those occurring in the renal bladder, in the prostate, in the vagina, in the cervix, and so on. But according to the literature, the prostatic cancer rarely involves the rectum because of the fascia in between, which is very firm. But this is an example of a prostatic cancer invading the bladder and the rectum. Then the one of the ways to spread to the of metastasis to the rectum is through the mesenteric reflections, and also by the bloodstream. Colorectal metastases are exceptional, and these are the most common three primaries to give rectal deposits: the lung, the breast, and the melanoma. Accurate diagnosis is relies on the histopathologic evaluation. It is suspected whenever you got a positive history of primary malignancy together with a rectal malignant appearing mass. This patient had a, a prostatic cancer that has invaded the seminal vesicles as well as the perirectal fat. And this patient had a lung cancer, and this is the lung cancer itself, a mass in the retrohilar area with invasion of the pleura and bilateral pulmonary deposits, and you got invasion of the rectal wall, the metastasis to the rectal wall from this bronchogenic carcinoma. And this is the breast cancer patient with multiple strictures in the rectosigmoid that has been proved to be metastatic lobular breast cancer. And another example, two different examples of metastasis to the rectum from breast cancer. You got diffuse thickening of the rectal wall with some stranding of the perirectal fat. And you may say, how can I diagnose this? It is similar to many of the previously discussed lesions. And I say, yes, you are right, but you feel that this rectum is not normal, and it is involved by a process, and this process may be an inflammatory or neoplastic lesion, and it wants further evaluation then the best way is to go by an endoscope and you have a biopsy from this lesion. If you put into consideration that the patient had a primary malignancy, you may consider that this lesion might be a metastatic deposit. And this is a patient who has too many problems. Actually, he has performed partial gastrectomy for gastric cancer 40 years ago, then right lower lobectomy for undifferentiated squamous cell carcinoma in the lung 10 years ago. Then he is taking medication for hypertension and the benign prostatic hyperplasia for the last 9 years. Colonoscopy revealed a abnormal rectal mucosa that was biopsied, and it showed adenocarcinoma. Immunohistologically, this adenocarcinoma was confirmed to be metastatic, secondary site. Abdominal CT showed the presence of a pancreatic tail mass representing pancreatic cancer with multiple hepatic deposits. And finally, you may also see rectal lipoma. And lipoma is one of the lesions that occur anywhere in the body, but it also can occur in the rectum. It is diagnosed very easily because of the density of the fat and the characteristic signal intensity of the fat. Finally, if you have a presacral cystic lesion, and this lesion is unilocular or multilocular with simple cyst criteria considered the duplication cyst. If this lesion is multilocular with mucinous content, calcification, internal septations, diffusion restriction, and variable signals of the loculi of the lesion, considered tail gut cyst. If the lesion has diffusion restriction with no enhancement, consider epidermoid. If the lesion contains fat and calcium, and you can consider dermoid cyst. If the lesion has fat and calcium together with cystic and solid component with little enhancement, consider teratoma. If the lesion is seen in a child with neurological symptoms, and this lesion has an intraspinal part associated with spinal anomalies, consider neuroenteric cyst. If you see the criteria of an abscess, diagnose abscess, like thickening of the wall, fat stranding, air loculi, and restricted diffusion. The anterior sacral meningeocele is diagnosed by the presence of sacral bone defect, unilocular lesion, which is connected to the CSF. Then to diagnose rectal wall hematoma, there may be history of trauma, which is common, hyperdense lesion on CT, no calcium, no invasion, and sometimes you see contrast extravasation. Hemangioma Philippoli are an important imaging finding. Nodular high signal intensity in the colonic wall on T2 weighted image, nodular mural enhancement, dilated perirectal vessels. In endometriosis, you got mushroom-shaped lesion in the anterior wall of the rectum with T1 and T2 high signal foci, which are characteristic if present. The vellus adenoma is a broad-based bulboid lesion leading to luminal expansion, carpet-like appearance, and enhancement with contrast. Colitis cystica profunda, submucosal lesions, peripheral enhancement, peripheral calcium, no diffusion restriction. Gist tumors are exophytic. They are bulboid expanding, extended to the ischiorectal fossa, calcium and hemorrhage 10% of the cases, no nodal deposits. Lymphoma, bulky bulboid mass, bulky lymphadenopathy, no ulcers, no obstruction. Carcinoid tumor, a small submucosal lesion, hypervascular, large lesions present by early deposits. Metastatic deposits are suspected by a known history of malignancy. Thank you very much.